Good morning, everyone. Thank you for joining us for this week lecture. My name is JP Brito, an endocrinologist at Mayo Clinic and co-host of these virtual sessions. I have the pleasure today to introduce Dr. Adomas Bunevicius. Dr. Bunevicius completed medical training and neurosurgery residency at Lithuanian University of Health Science in Kaunas, Lithuania. He was also awarded a PhD degree from Tilburg University in the Netherlands with a focus on patient-reported outcomes. He continued his clinical training at Brigham and Women's Hospital and Harvard University in clinical image-guided neurosurgery fellowship that focused on advancing imaging techniques for optimized surgical treatment of brain tumors. Subsequently, he completed a stereotactic radiosurgery fellowship at the University of Virginia under mentorship of Jason Sheehan. He's currently at Columbia University in the neurology program, and his clinical focus is neuro-oncology, and his research interest includes patient-reported outcomes and application of technologies to improve care for patients. Dr. Bunevicius is going to talk to us today about brain metastasis for patients with thyroid cancer. Dr. Bunevicius, thank you very much for accepting our invitation.
Thank you, Dr. Brito, for a nice introduction, and thank you for having me here today. So my name is Adomas Bunevicius, and today I would like to briefly talk about the management of thyroid cancer brain metastasis patients. I do not have any conflicts of interest. So epidemiology of thyroid cancer it's 1.3% lifetime risk, and with 54,000 new cases diagnosed in the US in 2018. The risk was steadily growing in recent decades, but it expected to plateau somewhat because of changed treatment screening recommendations for thyroid cancer, more conservative screening guidelines for thyroid cancer. So the most common type of thyroid cancer is differentiated thyroid carcinoma that comprise more than 90% of all thyroid cancers, and papillary thyroid cancer of those is the most common one. Prognosis of differentiated thyroid cancer is generally considered good, so 10-year survival generally exceeds 90 to 95%. Brain metastasis of thyroid cancer is a rare complication. So different registry data from all around the world have consistently shown that the incidence of brain metastasis in thyroid cancer patients is way less than 2%. According to SIR database, out of 90,000 patients with papillary thyroid cancer, only 100 of those patients also had diagnosis of brain metastasis. And as you can see on this graph on the right side, oftentimes brain metastasis develop in patients who have advanced disease. So for patients who have other metastasis to other, from thyroid cancer to other parts of the body. However, the discovery rate of thyroid cancer brain metastasis and metastasis in general, especially asymptomatic ones, is expected to increase, and it's increasing because of increasing discovery rate, which is due to increased adoption and increased quality of high quality brain imaging, such as brain MRI. Also, aging society and improved systemic cancer treatment options also increase the proportion of patients living longer with advanced cancer and who are at elevated risk to develop brain metastasis. Typically, it's thought and it has been shown that prognosis of those patients who have thyroid cancer brain metastasis is poor. Survival is rarely exceeds 2 years, and it has been shown that brain metastasis is a significant predictor of shorter overall survival, and it's stronger predictor of shorter overall survival as compared to other brain metastasis. So suggesting that those patients who have systemic disease, they have poor prognosis, but once they develop brain metastasis, their prognosis deteriorates even further. So how do we diagnose brain metastasis in general? So typical symptoms of brain lesions of brain mets, most common one is a headache. Also, patients can present with focal deficit, seizures, and other symptoms. However, this is usually caused by large brain lesions causing mass effect and disruption of normal brain function. However, more recently, as mentioned before, as we use more and more commonly brain MRIs for patients who are still asymptomatic, we discover more and more patients who don't have any symptoms, but they are just discovered with their brain metastasis in their head. And indeed, what we encounter in clinical practice sometimes is that brain metastasis can be a first sign of systemic cancer. So patients present with some neurological symptoms, and they are diagnosed with a lesion in the brain that looks like a brain met, or or brain tumor, and then you do biopsy and then we diagnose that they have a cancer and start treating that systemic cancer. So once patients present, imaging plays a key role in diagnosing brain mets. So brain CT is most commonly used, the first-line treatment, first-line imaging modality for patients who present with any symptoms, but that sensitivity is pretty low for diagnosing, especially small lesions. MRI is the best and most accurate imaging tool that we use for patients with brain tumors. And of course, biopsy is the most reliable method, so it allows to diagnose to assess histologic diagnosis of the cancer. So once patient is diagnosed with cancer, then we have decide on their treatment. And there's a myriad of treatment options for these patients that range from simple observation for patients who have, in general, poor prognosis and small asymptomatic brain deposit, to surgical resections for those who have large tumors causing neurological symptoms. Radiation therapy is a very important treatment for management of brain tumors and brain metastasis in order to optimize local and distant control of the intracranial disease. And of course, numerous systemic therapies and the emergence of, more recently, emergence of targeted therapies and immunotherapies for management of cancer. There's also an ongoing research efforts how to optimize control of intracranial disease. So, for example, focused ultrasound is being tested for opening blood-brain barrier to allow optimized penetration of chemotherapeutic agents to the brain across the blood-brain barrier. So it's being tested for patients mostly with primary brain tumors, but there are also studies in animal models to suggest that this tool can be utilized for treatment of metastatic lesions. However, it's still very early in the development phase, and it's not standard of care. So what do guidelines say about management of brain disease in thyroid cancer patients? So 2015 American Thyroid Association guidelines recommend surgical resection and stereotactic radiation therapy as mainstay therapies for cancer. They also speak about radioactive iodine treatment for treatment of those tumors that concentrate the radioactive iodine. However, it's not recommended as a standard of care. It's only after patients, for selected patients whose tumors uptake that iodine, and also after radiation therapy, and also together with steroids to prevent swelling of that brain metastasis causing neurological deterioration. According to European Thyroid Association guidelines from 2019, they recommend mostly radiation therapy for treatment of intracranial disease. What's missing though in these guidelines, to my views, is imaging recommendations for these patients. There are no really strong guidelines for or against doing brain imaging for patients who are asymptomatic for thyroid cancer. But 2012 European Association guidelines recommended brain imaging for patients who are asymptomatic and before initiation of any systemic therapy. So as part of this talk, we also did a systematic review of literature. So this is unpublished data. So what we did, we reviewed studies published in PubMed and Web of Knowledge databases up until February of this year. And the goal of the systematic review was to identify thyroid cancer brain metastasis treatment trajectories, treatment options that were published, also patient outcomes and prognostic factors. And this review included only studies with more than 5 patients, so case reports and small case series were excluded. So now we included 22 studies with a total of 570 patients with thyroid cancer brain metastasis, with sample sizes ranging from 6 to 113 years across studies. And as expected, most patients were diagnosed with papillary thyroid cancer, and different treatment methods were used to treat these patients. And this can be explained by the fact that these were retrospective series, so all patients were treated according to clinical need, and those who needed surgery underwent surgery, et cetera, so these were not clinical trials. And the survival of these patients across studies also range from less than 5 months to 33 months, although there are patients surviving more than 100 months of long-term survivals with this disease. And when we pulled all these survival time from diagnosis of thyroid cancer brain metastasis to patient's death, the pooled survival was 19 months. But again, standard deviation is high, like 21 months, suggesting there's large variability in patient survival after diagnosing brain mets. So then we tried to identify what are the important prognostic factors in this patient population. Individual studies have shown mostly that surgery and SRS is associated with better prognosis of these patients. So in 8 studies, that was identified as an important prognostic factor, either in univariate or multivariate analysis controlling for other confounders. Other important prognostic factors were worse functional status and greater number of brain metastases. Those were identified in 5 and 3 studies respectively. And this is not surprising because these are important prognostic factors in any cancer we speak about. Individual studies also found that older age, diagnosis of anaplastic thyroid cancer, presence of other systemic disease were also associated with worse prognosis of these patients, but these findings were reported only in single studies. And one study found that the use of TKIs was also associated with better survival. So then we did meta-analysis of the study. So we aimed to compare what's the impact of surgery, of resection or SRS for survival. So how much does it prolong patient survival? So for this analysis, we selected 10 studies, and those were selected basically mostly from those 22 original initial studies that were found in the initial systematic review, but only those studies that provided sufficient data were included. So mainly studies that provided at least mean or median and standard deviation of survival after treatment and had at least both groups of treatment of patients reported in their study. So these 10 studies included 153 patients, and of those, 82 underwent resection or SRS, radiosurgery, and 71 did not get neither of those 2 therapies. And what this showed that the use of surgery or resection or SRS had important survival benefits of patients who received that treatment lived on average 1 year longer as compared to those who did not. So suggesting that this treatment can be beneficial. However, again, it should be interpreted with great caution because these were retrospective series. So there is a large concern for selection bias, so that patients who were of better functional status and their systemic cancer were better controlled in real life are more likely to be selected for more aggressive therapies, and especially surgical resection of the disease. So what do guidelines say about surgery now? So according to ASTRO guidelines, surgery, speaking about all cancer patients, not only thyroid cancer, but surgery must be offered to all patients who have suspected brain metastasis and brain imaging and do not have a primary cancer diagnosis. Also, surgery should be offered for those patients who have large tumors causing brain compression and neurological symptoms. On the other hand, the patients who have multiple brain metastasis or uncontrolled systemic disease, in this patient population, surgery should be offered with caution, given that it's an invasive treatment method associated with complication risk that can further deteriorate quality of life, and that can be important for patients whose expected survival time is short. According to Congress of Neurological Surgeons guidelines, they recommend surgery and whole brain radiation therapy as a first-line treatment, and these guidelines were from 2019. But they also, given that there's stronger evidence to suggest based on randomized clinical trials. However, this is less so based on randomized studies, but as stereotactic radiosurgery is really now more commonly used than whole brain radiation therapy. It's just the level of evidence is lower given the study design. So how do we treat, how do we operate these patients? So first of all, it's important to select good surgical candidates. So for that, we consider the functional status, their status of systemic disease, and their expected survival. And as mentioned before, those with poor functional status and short expected survival and uncontrolled systemic disease are less likely to be offered surgical treatment of their brain metastasis. It's not to say that it will not be treated, so it can be treated with other less invasive therapies such as radiation therapy, which has much lower upfront complication risk. And then when we speak about surgery, we speak about different surgical approaches. So ideally for brain metastasis, we perform gross total resection, and that can be feasible for brain metastasis, treating the lesion that we see because of a typically clearer margin between tumor and normal brain tissue as compared to other intrinsic brain tumors such as glioma. So margin is better, and we can achieve gross total resection in majority of brain metastasis patients. However, then that's not feasible. We can perform subtotal resection, but that's less commonly done in for brain mets. And for lesions that are small, deep, and eloquent, we can perform stereotactic biopsy or using image-guided biopsy. So to be precise, just sample a small tissue and to make a diagnosis. That's typically offered for patients who don't have a cancer diagnosis on hand, or they have a comorbid cancer diagnosis and it's not clear which one spread to the brain, and their treatment options are completely different. So main benefits of neurosurgery is histological diagnosis, symptom relief, and improved survival. And the risk, again, it depends, but it's really it's less than 10% of major complications of surgical resection, and that can include neurological worsening, infection, stroke, and then hemorrhage. Now, quality of surgery is improving in years, so in particular, improvement of surgical planning approaches, and so we routinely use image guidance to guide us to brain lesions and to brain metastasis, and to kind of go on target and not to wander in the brain. And also, for some patients when needed, we can do more advanced surgical planning. So this on the right-hand side, you can see, for example, it's one of the patients we treated who had a tumor in the left dominant hemisphere. So a high-functioning patient so for this patient, we were, as for all patients, we want to preserve their function. And here you can see different brain tracts surrounding the tumor. So we want to see that beforehand, before surgery, so that we plan our approach, our trajectory accordingly, so not to damage these important tracts. For example, you can see here a corticospinal tract kind of surrounding the tumor, so we don't want to hurt that structure and cause hemiparesis to the patient. What we can also do is a functional brain MRI and use that for our surgical strategy and during surgery. Use that for navigation. So on this lower panel, you can see the functional brain MRI data of this patient. So that can show us which is the safest entry zone to the brain to access this brain tumor. So we have tools we can use as needed to improve safety of surgery. So then there is more other treatment options that are more experimental, not as experimental, but they're not so commonly used for brain metastasis in the upfront settings, such as laser interstitial thermal therapy. So this includes introducing a very tiny probe using stereotactic techniques to a lesion, and then heating that lesion up. So, and however, for that we need some technological advances, technological things in our disposal, such as our possibility to do MR thermometry, so what could measure real-time heating of the brain, because first thing, we don't want to make harm to these patients. And this treatment is used more often for radiation necrosis after radiosurgery of brain metastasis. It's less commonly done in upfront setting for brain mets, although theoretically it could be used. You could do like a brain tissue biopsy and also perform treatment in the same sitting, so that the patient could receive a diagnosis and also treatment during the same surgery. But experience is limited. So this is, for example, a series from a large multi-centered series in the US. From the US, that included only 13 patients who had for treatment of brain metastasis. And this possible advantages of this treatment is that can allow to decrease radiation dose, and this can be effective also theoretically for more radio-resistant tumors. And so that can be considered, although as mentioned, it's typically used for radiation necrosis. So radiation therapy. So radiation therapy is critical treatment. It's very important treatment method for treating brain metastasis. The idea why that is that local recurrence rate after resection of brain mets is very high. It exceeds 50% and reaches up to 70% over 6 to 12 months. So more than half of patients experience disease recurrence at surgery site within 6 to 12 months. Because even so, during surgery, we remove the tumor, perform what we call gross total resection. So we remove the tumor that we see, but we cannot see all this microscopic spreading and microscopic infiltration of cancer cells around the disease. So radiation therapy, what it does, it helps us to control the disease, so to kill those remaining cells in tumor beds surrounding the radiation cavity. So this is a landmark clinical trial showing the effectiveness of such approach. That was published, I believe, in JAMA in '98. In this study, patients were randomized to either surgery alone or surgery and whole brain radiation therapy. And what they found that patients who received post-operative whole brain radiation had much better disease control in the brain, and also post-operative radiation increased the local control and also distant control of brain disease. Because whole brain radiation, we irradiate the whole brain, so that treats not only the tumor bed but the whole brain, and that helps to control this potential disease spread in other areas that are outside of our resection cavity. Although overall survival was not different between the two studies, and that should be likely because patients died of just systemic progression of their cancer, but what radiation also did is that it decreased the likelihood of neurological death, so meaning that less patients died from disease progression in their brain. So what do guidelines say about that, about radiation therapy? So according to ASTRO guidelines, again, symptomatic brain metastasis should be offered local therapies to control the disease, regardless of the systemic therapy used for treatment. And for patients who have asymptomatic brain metastasis, they also recommend local therapy that it should not be deferred. So practically, we offer radiosurgery for small lesions in the brain, for small metastatic lesions, just to better control the disease. So because we know that the effectiveness of SRS is better for smaller lesions. Again, similar as to surgery, one has to consider functional status of a patient before pursuing any treatments, including radiation therapy. So now, again, this is also an interesting topic in radiation oncology, saying that how many metastases can we treat and which treatment method we should use. So according to these guidelines, SRS is recommended for 1 to 4, up to 4 unresected brain mets and 1 to 2 metastases that have been resected. So that's a traditional thinking that that number of brain mets limits the use of SRS. However, in reality, and what data is showing is that we can treat much more than 4 lesions with an SRS. So in the same guidelines, they also recommend that SRS should be considered for those patients who have more than 4 lesions, and they have good functional status and systemic disease is well controlled. And I'll tell you a little bit about why that is recommended. So whole brain, slide about whole brain radiation. So whole brain radiation allows to deliver a dose of radiation over several fractions, typically, so it's 2 gray per fraction, and we can fractionate that over 10 fractions or more, depending on patient's functional status. And practically, it's now more commonly reserved for patients who have multiple brain metastases, tiny lesions, but just too much for SRS, and also for those with poor functional status. Patients who have poor prognosis, just to ensure their control of intracranial disease rather than go for curative approaches. So SRS, what it does, it allows better intracranial, so it decreases the likelihood of distal recurrences. So it helps to control the local disease because we already get the whole brain, but also treats any lesions that there are outside of the brain. What's a problem with that is that we treat the lesion target, but we also irradiate the whole brain in healthy brain tissue, and that can cause important adverse events for patients, such as cognitive function deterioration, decrease of quality of life, and this can be very important for patients who have cancer with good prognosis, such as, for example, differentiated thyroid cancer. So memantine and hippocampal avoidance are now also used with whole brain radiation therapy to decrease the likelihood of this from happening. So stereotactic radiosurgery. So it's a different approach to whole brain radiation therapy and different philosophy of treatment. So what radiosurgery does, it allows us to deliver very high dose of radiation very precisely to the brain with very high precision and accuracy. So it works as any radiation, creating ionizing electrons that cause DNA breaks and necrosis of apoptosis. But another important aspect of SRS is that because of its high radiation dose, it also causes endothelial damage within the lesion, and that causes causing ischemic changes in the tumor as well. So when we plan treatment, we always think about this therapeutic window. So what we want to deliver as high dose as possible, but not causing complications. So here, if we increase the dose, the risk of complications is increasing, although it's a safe treatment, but still, we know that it's changing. And I'll tell you how we try to mitigate this risk in clinical practice. So also we think about how resistant tumor is to radiation therapy and what dose is needed, what's the optimal dose for this tumor. So we think about alpha-beta ratio that kind of corresponds to radiosensitivity of the tumor. And also during radiosurgery, because we deliver very high dose of radiation, we have to be very mindful about surrounding structures, so not to cause harm to patients. So in particular, for tumors that are close to optic nerves, we have to plan our treatment accordingly so that we don't hurt these optic nerves and do not cause optic neuritis that can cause blindness for a patient. So typically, the goal is to deliver less than 8 rays of radiation to optic nerves. Another important structure is brainstem, and we have to think about treatment planning and blocking some shots if needed so that we don't cause harm to these patients. And as for thyroid cancer, from what I know, there's some concern about radio resistance of this tumor based on clinical studies and some preclinical data. So we should probably aim for higher dose, escalate the dose as much as possible for this cancer, for thyroid cancer brain mets patients. So there are different tools to deliver radiation, stereotactic radiosurgery. So the most commonly used and have most experience with gamma knife. Another technique is CyberKnife, or Linux can be used for delivering radiosurgery as well. And what we know from our experiences and from published data that stereotactic radiosurgery allows to achieve local disease control in way more than 90% of patients. So it's very effective treatment method, irrespective of delivery method like SRS, CyberKnife, or LINAC. And again, but this estimate comes from other more common cancers that are more likely to spread to brain, such as lung cancer or melanoma. So radiosurgery can be used in adjuvant settings. So after tumor resection, we can treat tumor bed, but also as an alternative to surgery. So if we see a lesion that we can treat with a radiosurgery safely, we can treat it because that's much less invasive treatment than open surgical approach. Importantly, the patients ask this oftentimes in clinic, does it increase risk of other brain cancer? So the answer is no, because there is a strong data paper published recently in The Lancet showing that stereotactic radiosurgery does not increase the risk of secondary brain malignancy, just because how we deliver treatment, the surrounding brain structures and intracranial structures and dura receive very little dose of radiation to cause any risk to develop secondary cancers. And also, technology is evolving and treatment envelope is expanding for this using SRS. So we can treat very eloquent brain lesions, even those that are in the brainstem and close to optic nerve safely. Also, we can treat multiple lesions, way more than 4, and I'll show some data from our experience with thyroid cancer. And we also can treat large tumors, so tumors that traditionally were considered to be too large for SRS. Now we can treat those using hypofractionating approach, so delivering radiation over typically over 5 days. So it's a safe treatment method. The risk of adverse events is low. It's way less than 10%. An important immediate post-SRS risk is swelling around the tumor. That's sometimes that can cause symptoms, and we can treat it very successfully. Radiation necrosis is a complication that can happen later after treatment course, but the risk is less than 5%. And these both complications can be treated with steroids. Typically, steroids help very nicely. So taper of steroids over a week and symptoms improve. If that doesn't help, we can try Avastin. And if that doesn't work, so for a very selected number of patients, we can use more invasive treatment method to treat their radiation necrosis, such as laser therapy and or resection if needed. So a few words about gamma knife. So gamma knife uses cobalt as a radiation source that emits gamma rays, and it has 192 focus beams that basically focus in one point in space, which we defined during our planning. And this is where treatment is happening, right? So different beams intersect at one space, and then the radiation is the highest in that focus point or points. So it can be used in the single session using the stereotactic frame. So for this, we use a special frame that's attached to patient's head. It has 4 pins that penetrate the skin and sit tightly on the skull. And that gives us very high precision, the sub-millimeter precision and accuracy. If you use hypofractionated approach, so we have some, somewhat a margin for error. So because we deliver a smaller dose of radiation, so we can use a mask, a special thermoplastic mask for a patient. So that's a bit less invasive, but it takes 5 days for a patient. Nonetheless, needless, it's still outpatient procedure. So either use frame or a mask. We don't typically admit patients for treatment of SRS. It's not needed. And also, so that defines dose. So traditional dose of SRS in a single fraction is in a ballpark like from 16 to 24 grays. Typically, is enough to treat most brain metastases. What we use for planning, we use T1 weighted brain MRI thin sliced, and that should be done within 1 week of treatment, so that we treat all lesions that are present in the brain. We don't miss anything. And we use this MRI for treatment planning. And once patients have the frame on during the day of procedure, they also undergo a CT scan of their head with a frame on. So and then we merge those two scans, CT and MRI, and treat patients. And of course, these patients have to have imaging follow-up after treatment. It's typically every 3 months for the first 2 years. So this is an example of one of our patients treated with SRS for thyroid cancer intracranial metastasis. So 65-year-old female, with 4-year history of follicular thyroid cancer metastatic to the brain, also had mets to lungs and sacrum. And this patient was treated extensively before. She underwent thyroidectomy, radioactive iodine treatment, and also received MEK inhibitor, and she presented with diplopia. MRI showed this clival enhancing lesion, and that, as you can see, the lesion is here and brainstem is here, so it's very close to a brainstem. So it was treated with gamma knife radiosurgery, delivering 25 grays for radiation, and also her systemic therapy at that time was changed to TKI. And at 11-month follow-up, as you can see, there is still, you can see a clivus does not look healthy and normal, but the pattern of enhancement has changed. So we consider that radiation is working in tumor. It certainly is not burn. That's another case of a 71-year-old female with papillary thyroid cancer that discovered at the time of initial diagnosis. If you can see this tiny spot here, it's a asymptomatic lesion on the left in the left frontal area that was treated with radiation therapy, and we can see on the lower panel we can see that 15 months after radiation surgery that dot disappeared. So SRS worked. So important advantage of SRS, as mentioned, is cognitive preservation, and that's in particular for patients with thyroid cancer who have long prognosis. So this is a randomized trial published in 2017 that randomized patients to either SRS or whole brain radiation therapy, and they followed their cognitive function every 6 months. And what they found that the risk of cognitive deterioration was significantly greater in whole brain radiation group as compared to SRS, so 85 versus 52% respectively. Although median overall survival did not change. One thing what we know is that the patients who received whole brain radiation had much better had better intracranial control of the disease, basically, especially in areas outside of the initial tumor. So we know that, but nonetheless, the risk of cognitive functioning was much higher in whole brain radiation group. So that's an important point to consider when selecting treatment methods for patients. And another important thing to consider is quality of life. So this is our experience with 44 cancer patients who underwent over 100 gamma knife radiosurgery procedures. So we monitored their quality of life using EQ5D questionnaire. It was administered before SRS at 2.6 months after radiosurgery and 14 months after radiosurgery. And what we found, and these only patients treated with gamma knife radiosurgery. So what we found that in these patients with advanced metastatic cancer to the brain, their quality of life remained stable over follow-up, overall quality of life, as well as their mobility, usual activities, pain, discomfort, and anxiety, depression. The only thing that was worse during follow-up is the proportion of patients having difficulties with self-care, and the proportion of those increased from 9% pre-SRS to 18% at last follow-up. And this is another study we did, published last year in Thyroid. So this is an international multi-center study of patients treated with gamma knife for thyroid cancer brain metastasis. So this International study included 10 centers from 5 countries, and we included patients who had a histological diagnosis of papillary or follicular thyroid cancer, did not have any other active cancers, and they were treated with single-session SRS and had at least one follow-up after treatment. We did not include patients who were treated with fractionated approaches or had other types of thyroid cancer. And as mentioned, all patients were treated with gamma knife radiosurgery, and clinical or imaging follow-up was every 3 months. So in this study, we included 42 patients. So most patients were diagnosed with papillary thyroid cancer, and there were 7 with follicular one. Also, what we found that most patients were diagnosed incidentally. So 15 patients, not really most, but were asymptomatic. A large 2/3 of patients, 1/3 of patients. I'm sorry. So what that says, that at least in centers that participated in this international initiative, was that patients with thyroid cancer underwent brain surveillance, brain imaging, even if they didn't have symptoms. So this is a common practice in the real world, it seems like, based on this data. And the most common symptom of those patients who had any symptoms was headache. And these patients were heavily pretreated, so most of them underwent thyroidectomy or radioactive iodine therapy. Also, 10 patients had craniotomy, so suggesting that, we can look that into SRS as an first-line treatment, but also as an adjuvant treatment, so we can compare both treatment options. And median number of brain metastases was 2 in a patient and ranged up to 10. So again, that shows that patients with thyroid cancer brain mets, so 4 is not a limit, and we know that really, but this just showed that we treated patients who had up to 10 brain metastases. And size of lesions also varied, so very tiny asymptomatic deposits to larger tumors causing symptoms. And margin dose was 20 gray, which is a typical dose for brain metastasis. And for clinical follow-up was 15 months, and during this time, 16% of patients died. And when we looked about causes of death, unfortunately, this was available only for 8 patients. But what it showed really that only 1 patient died from CNS cancer progression, so suggesting that the likelihood of death from CNS progression in patients with advanced thyroid cancer is reduced in those who undergo SRS. And median time from SRS to death was 14 months in our experience. And when looking into predictors, so in this analysis, it showed that, as in line with previous studies, greater number of brain metastases and lower functional status were associated with shorter survival in these patients. Then we looked into disease control, so how we control this intracranial disease, because this topic was not really carefully addressed in previous studies published, because what they did, they focused mostly on overall survival, but did not perform this assessment of disease control in the brain. So we tried to do that, and so our imaging follow-up was almost 2 years. Only 5 mets of all treated brain metastases experienced, 4% experienced local failure. So meaning that 96% of treated lesions responded to treatment well. And at last treatment follow-up, the vast majority of patients experienced either complete or partial response or had a stable disease. So suggesting that it really helps to allow intracranial disease very nicely. With regards to safety, patients did not experience any adverse radiation events, and there are some patients who experienced this transient peritumoral swelling that was managed with steroids and did not require any surgical intervention. So it basically was self-limiting or was treated with steroids, and that's it. So that's SRS. So now a few slides about chemotherapy. So as you know much better than I do about treatment of chemotherapy of these patients, treatment options, number of treatment options is increasing. So we can use multi-target kinase inhibitors and also mutation-specific more targeted therapies. So what I did here, I really looked into those clinical trials, how well they represent patients who have brain metastasis. So my impression was that the majority of these clinical trials either excluded patients with who had brain metastasis up front, or did not include brain metastasis because it's just such a rare complication. Also, those patients, there are studies that included patients with brain mets, but what I could not find in those studies, the results showing how it helps to control intracranial disease. So data from these clinical trials did not directly address intracranial control rate of thyroid cancer. However, there's one study recently published of 24 differentiated thyroid cancer patients with brain metastasis that included 24 patients, and half of them received TKIs, 8 as a single agent, and some patients required multiple agents. And what we found that overall survival was much longer in those who received TKIs as compared to those who did not. So median survival was 27 months in those who were treated with TKIs as compared to only 5 months as compared to those who were not. However, this should be also interpreted with some caution that it's a retrospective series, so subjected to selection bias of patients, better patients receiving more aggressive treatment. So further research is needed to better define the role of TKIs in controlling intracranial disease of thyroid cancer patients. So to conclude, thyroid cancer is a rare disease, and thyroid cancer brain metastasis is a very rare complication of this disease. Way less than 2% of patients develop thyroid cancer. So we know that early detection is critical for better control of intracranial disease. However, there's no strong guidelines to suggest that if routine imaging is needed. And what our experience shows that a lot of patients, though, receive brain surveillance, even in the absence of neurological symptoms, and even considering the rarity of this complication. So resection and SRS are mainstay treatments of brain metastasis, and resection is typically used for patients who have large symptomatic tumors, whereas SRS can be used for small tumors, and it's very versatile treatment, and it can be used in many different scenarios for patients with brain metastasis. Whole brain radiation therapy is traditional treatment, but it's now typically reserved for patients who have a widespread disease and who have poor prognosis, and given the increasing risk of cognitive decline with this treatment, which can be of particular importance for patients with thyroid cancer who have good prognosis. And also those patients who are diagnosed with a thyroid cancer brain met should undergo imaging follow-up afterwards. So typical protocol is brain MRI every 3 months. And again, further studies are needed to better define the role of TKIs for management of this complex disease. Thank you very much.
Thank you, Dr. Bunevicius. Fantastic presentation, and congratulations on the research. I did follow closely your last publication in thyroid. I think it was very, very helpful. Dr. Bunevicius, from the perspective of the clinician and the surgeons, let's imagine the case in which I have a patient that has advanced thyroid cancer with metastasis to the lungs and bones. When should I think about doing imaging studies in the brain? And if so, which imaging would be the one that I use?
Thank you. That's a very good question. So I think, also biased given my training, but I think that brain MRI should be done for these patients, especially for those who have a metastatic disease, because there's some data to suggest that this is a risk factor can be a risk factor for brain metastasis. Although it's rare, but so once we diagnose brain metastasis until they are asymptomatic, we can treat those and preserve patients' quality of life. So not to wait until the cancer grows and causes some paralysis, and that can be really devastating for anyone. So we can treat very tiny tumors very safely with stereotactic radiosurgery. So I would be in favor of performing brain imaging, and the imaging of choices is just a brain MRI, 1.5-3 Tesla brain MRI, and we need contrast enhanced scans to see brain lesions, because brain metastasis typically uptake contrast, and that helps us to see the lesion much better. So I think that these patients should be candidates for brain imaging.
No, great. And I noticed that in one of the guidelines, it was also suggested a brain MRI in those patients who we are considered TKIs before TKI therapy. I imagine that they are concerned about some adverse effects of this, or just mostly to readdress the need of TKIs in the setting of brain metastasis.
Yeah, so this interesting guideline, so it was recommended in, I believe, 2012 European Association guidelines, but then in the most recent version in 2019, they did not speak about it. Okay. So I don't know what changed in the interim, and again, I think it's better to diagnose cancer early, but when given that if it's a common disease and MRI is an expensive diagnostic tool, so then cost can add up for patients, and the risk of brain metastasis is high. So I guess more research and then thinking is needed to identify optimal candidates for this diagnostic intervention.
And thank you. And in line to that question, a member of the audience is asking, if you do this screening from brain mets, patients are asymptomatic, and then it's negative, how often do you keep doing it for patients who have advanced thyroid cancer and maybe you are already using TKIs?
That's a good question. I would better defer this question to endocrinologist, someone who follows these patients more closely. Typically, when we get referrals, patients already have a diagnosis of a brain. But another important thing, I guess, to consider is the type of treatment, right? Because nuclear cancer are most used often in this setting. But what happens with intracranial lesions, they're typically not sensitive enough to detect very small lesions, so very small asymptomatic lesions. So PET is good, or a SPECT scan is good for large tumors, but for tiny brain metastasis, it might not pick them up. So we might miss those if we're using nuclear imaging only.
Okay, good to know. And okay, the clinician, the surgeon sees a patient and he has some brain mets, let's see, 2 brain mets. When should we go pick up the phone, call you right away versus say, okay, we have time, this is a regular consult to neurosurgery or neurology? And if so, when should we think about the steroids, how we should think about the steroids and anti-seizure medications, if needed?
Yeah, thank you. It's a good question. So typically when patients have brain mets, I think it's good to consult a neuro-oncologist or a neurosurgeon, and for a patient who has a known cancer diagnosis, right, a thyroid cancer diagnosis, because then we know that the smaller the tumor is, the better control and safer our treatments are. So the earlier we treat, the better for a patient. So we want to know as soon as possible so that we could choose least invasive treatment modality. With regards to, and also patients who have symptoms, we probably need surgery, but again, that's what happens us, at least in Columbia here, we have multidisciplinary board. So when we are not clear, we discuss these patients on our board, and we have a special board for brain metastasis patients. So we discuss like neuro-oncologists, radiation oncologists, surgeons, what's the best approach for this patient. And that happens every week. So if a patient is referred to us, if it's not clear what to do, we'll talk about it within a week. So that's important to do that. Yeah, it's that time. Oh, and with regards to steroids,
yes.
So again, that's an interesting question, because sometimes if we know that patient has brain metastasis, so we can give steroids for patients who have a symptomatic brain metastasis, for a patient who has a headache. Sometimes, though, it's tricky to give steroids up front for a patient who does not have a known cancer diagnosis, because, for example, if he or she has lymphoma, the use of steroids can make a diagnostic approach more difficult. So then we prefer not to give those before we do a biopsy, so that we could diagnose the disease. But if a patient already has a diagnosis, we can give steroids.
And it would be dexamethasone up to, what is with the frequency and the dose? Is it 4 milligrams daily?
Yeah, 4 milligrams 3 times daily.
Okay, 3 times daily. And for how long would you do it? Until symptoms improve, or until is treated?
Yeah, until symptoms improve. Patients with brain mets don't need long-term steroids. It's a symptomatic treatment because of side effects of this therapy.
No, that makes sense. Now, I have always thought that the biopsy in the brain it always gives me the sensation that it's not the same that biopsy in any other place of the body. When should we think about biopsying these lesions? Of course, sometimes it's clear when the patient has only thyroid cancer, but often we find patients that sometimes might have another cancer. So when should we think about biopsying these lesions?
It's a very good question. So typically if a patient, it's a simple scenario. If a patient has one cancer and 1 lesion, we don't need to biopsy. When we need to biopsy, the patient does not have a diagnosis of cancer and has a brain lesion. Now, if a patient has 2 cancers and that can happen, then it depends. Like what we sometimes think about radiosurgery is it depends on systemic therapy. So if we know the patient has two cancers, we treat both of them. If the patient is a candidate for SRS, their lesions can be treated with SRS. So sometimes it is thought that, SRS is the most targeted treatment for cancer because we treat what we see, right? It's not, it's different kind of approach as compared to targeted therapies considered molecular biomarkers. But here we can very precisely treat what we see. And typically the dose does not change. So we use like 20 grays plus or minus for brain metastasis. So it does not really matter for us so much to some extent if we treat the brain metastasis. If it's like lung cancer or thyroid cancer, we can still use 20 grays and achieve a good control of intracranial disease. And then it boils down to how we manage to control their systemic disease to decrease the likelihood of that. So biopsy in these cases are not really necessary for a patient who has a known cancer diagnosis.
Okay, that's perfect. And there are many other questions from the audience, so I will start reading some of those. So one of the questions is about timing of external beam radiation versus the timing of radioactive iodine. And you mentioned that it was suggested external beam before radioactive iodine, perhaps thinking about potential swelling of the tumor after radioactive iodine. But there's also the concern that if you do external beam, you can actually decrease the efficacy of radioactive iodine because you pretty much destroy perhaps the mechanism by which radioactive iodine become effective. Do you know any evidence about the timing of this, or if this is an area of more recommendations from experts?
Yeah, it's not my area of expertise with radioactive iodine, so I cannot comment. What that guideline says, though, is the American Thyroid Association that you should they recommend giving external beam radiation before radioactive iodine to prevent swelling, and also give steroids with radioactive iodine. So maybe that's.
And in our experience, you're right. In our experience, I think it will be very rare that we consider radioactive iodine. These patients usually already have aggressive disease to begin with. They're usually radioactive iodine resistant, and so. But I think it's an interesting question as well in regards to the timing, and that timing question also happens in other areas. Another question is in regards to the use of systemic therapy while external SRI is being used. They recommend the medical oncologists and endocrinologists to stop systemic therapy that while they are treating the lesion. So do you continue?
We can continue systemic therapies. That's a common practice. And what's also sometimes now more and more this starts being about abscopal effect. So when we treat a lesion for patients who have immunotherapy, so we can activate the immune response that helps to fight cancer elsewhere in the body, kind of expose the immune system to cancer antigens. So yeah, we use treatment. So sometimes with immunotherapy, we would think more whether to stop or not, but for targeted therapies, we can continue that.
Perfect. And another question is the possible role of VEGF therapy in regards to the potential of increasing risk of brain metastasis because of the mechanism of losing the blood-brain barrier. So to what extent that is any evidence for that?
No, not really. In reality, we often use Avastin for treatment of radiation necrosis, which is resistant to steroids. No, there's not. The only thing from surgical perspective, though, with Avastin is that there can be a problem with wound healing. So for patients who need an open surgery, craniotomy, and who are on Avastin, so we like patients to stop that before surgery for at least a few weeks. So that to decrease the life, because that interferes with wound healing because of prevents proliferation of blood vessels, and that can cause complications higher up, not inside the brain. But with regards to, it's an interesting idea. It's whether it will increase metastatic potential, I don't know, but I don't think there's data about that.
Yeah, no, that makes sense. And then what about the role of immunotherapy for brain mets with surgery or even without surgery? If not data in thyroid cancer, what about data from other cancers?
For thyroid, so we use immunotherapy, and there is some data emerging that immunotherapy can be effective for even as a monotherapy in some cases for management of intracranial disease, not helping patients for SRS or any other therapies. But again, that's if we see a treatment, the most targeted treatment is radiosurgery. We can treat these lesions with SRS and forget about it and then move on for that patient and use immunotherapy if needed for other reasons for that patient. So typically immunotherapy is not thought to be as a treatment of choice for brain metastasis because we have SRS, we have surgery, we have radiation therapy. But yeah, we discuss in boards and we discuss with our colleagues about whether we need to stop the treatment, if it's safe to stop this treatment for SRS, or we can continue that during the course.
Okay, thank you for that. And then, is any evidence that brain metastasis from thyroid cancer has same, worse, or less, or better prognosis than brain metastasis from other cancers, or once that we have brain metastasis, the prognosis is the same for any cancer?
That's a good question. Typically, it's hard to say because yes, data shows that patients who have brain metastasis from thyroid cancer have worse prognosis, and that's also true for other cancers as well. But we have, I think, pretty good treatment options for intracranial disease now with an SRS, because that's not a limiting factor for their survival. It just, once you have brain mets, it just shows that your systemic disease is poorly controlled and treatment is not working. We have to think about changing that treatment because we can control brain disease in the brain, in the CNS, but again, if we don't control the underlying cause of that complication, then the prognosis is poor. So that's what's driving should be considered in these patients strongly, like just good systemic control of their cancer.
Oh, fantastic. And let me throw a question here. Again, I know this is rare, but there are some thyroid cancers, actually the vast majority that even if they have metastasized to the lungs and to the bones, they continue to be slow growing. We don't always act right away. Sometimes we just wait until they become symptomatic. I imagine that you cannot just let these lesions become symptomatic in the brain, of course, but there is any evidence in regards to how fast they grow once they are small, perhaps picked up incidentally? Are the ones, the majority stay the same, or are those things that they grow very fast and symptoms clearly are coming and we should treat it right away?
That's a good question. So in general now, in neurosurgical literature, it's hard to do these natural observation studies of intracranial disease. We have some data from, for example, more benign tumors such as meningiomas, where we can allow them, and it's not really clear when we have to treat those, but we have data for that. For patients who have aggressive cancer, we really don't have good data to say what's the growth rate of these cancers, and we prefer to treat those. So there's no strong, I'm not aware of data, especially for thyroid cancer.
No, I understand. Dr. Bunevicius, this has been a fantastic presentation. We're really, really thankful for coming here. Feedback from the audience is, thank you, a fantastic presentation as well. Dr. Bunevicius, again, extending the invitation for the future to come back. We do have grand rounds, 2 more boards. We have journal clubs, and certainly, having the thoughts and questions coming from somebody that treats patients with thyroid cancer with brain metastasis is always welcome. So I appreciate your time and the fantastic presentation as well. Also extending our thanks to the audience for your fantastic questions, and also extending the invitation to the audience to use TIRO. TIRO is an application that was developed by experts using the recommendations by guidelines and coming up with recommendations that help you in the practice with your patients and every day. And with that, we just extend another invitation for you to come next week and to continue your fantastic questions and contribution to the field. Thank you very much. Take care.
Thank you very much. Bye-bye.